We tracked 61 people longitudinally after getting mRNA vaccination. And I think one of the key things that we're still struggling with in the field is understanding what the long-term immune memory looks like after mRNA vaccination. So we were able to take 60 or so people out to 6 months, examine not only their antibody, but also their cellular immune responses. So memory T cells, memory B cells, and track the ability of those populations to become established and ask how durable they were. And I think really the key finding was that even though antibody levels decline over time, over 6 months, the memory B cells, the cells that actually make the antibodies, are really stable. And in fact, their numbers get better over time in people that had never experienced COVID. And they have incredible breadth in the ability to recognize variants, including the Delta variant, the Beta variant, which is the South African variant, which is often very hard to neutralize. These memory B cells have good specificity for these variants. If you activate the memory B cells, they make antibody really quickly. And so they, I think, afford a level of protection. So it's sort of a backup plan. If your antibody levels go down, while that may mean that you might get a mild infection, the memory B cells, and actually there were stable memory T cells as well, they sort of kick into gear quickly, can suppress that infection, prevent you from getting really sick and ending up in the hospital.
So do you think that that might reflect why we see over time an increased risk, I guess, of infection post-vaccination, but that doesn't seem to correspond with a necessarily like increased risk for hospitalization and severe illness, death, etc.?
Yeah, that's right. I think there have been a couple new studies. There was a nice new large study from the Kaiser Permanente group in California of about 3.5 million people out to 5 or 6 months, showing that while there was an increase in the rate of infections that were registered in the health system, the protection against hospitalization and severe disease remained at around 90%, 85 to 90%. So I think what this is telling us is immunologically, when you have antibodies in your blood, in your mucosa, those antibodies act as a bit of a shield. They prevent the virus from ever getting in. But antibodies naturally decline over time. You have variants of viruses to worry about, not just SARS-CoV-2, but influenza virus. And so sometimes you need a backup plan. And those memory B cells and memory T cells, well, they can't prevent the virus from getting into a few of your cells. Once that happens, those memory B cells and memory T cells jump into gear really quickly. They can prevent the virus from spreading within your body. They can limit the symptoms to really just being relatively mild and the course of infection to being much shorter. So especially with SARS-CoV-2, that's really critical. One of the things we really need to prevent here is the virus getting deep down into your lungs, where you start to see that deep lung infection, pneumonia, and that's when things can really go very poorly.
What do we know about what happens to the immune response when you have been exposed post either vaccination or post having a natural COVID infection?
Yeah, it's a great question. So, experiencing COVID infection does also generate immunological memory. What we do know is that immunological memory is different in some ways from getting vaccinated. And so we're seeing that the rate of protection from natural infection is close to what you get with vaccination, maybe a little bit different. There are studies that differ on this. Some studies say it's better, some studies say it's a little bit worse. But what we don't know with natural infection is how durable that immunity is going to be. We think it's going to wane over time based on what happens with seasonal coronaviruses. Now, we don't know that much yet about the immune response of people who get infected after they've been vaccinated. That's still clearly a place where a lot of us are focusing a lot of attention, but it's very hard to capture those events because they're relatively rare and they don't end up in the hospital. So we're not seeing them in places where you could actually capture them and study them. We have looked, and in this paper we study about 1/3 of the group of people we studied actually had COVID first and then got vaccinated. We were able to use that to understand what an additional response might look like. And in fact, in that order of events, COVID-19 followed by vaccination, you get really strong boosting of antibodies. You get mild to moderate boosting of these memory T cells and memory B cells, but that increase in the antibody probably means you're going to be protected much better. And so this gives us some insights into what might happen with booster vaccination. that we boost and sort of top off the antibodies for a while. That prevents us maybe even from getting infected at all. Certainly helps prevent us from getting severe disease and end up hospitalized.
So when you look at the people who had a SARS-CoV-2 infection and were subsequently immunized, do the antibodies hit a sort of a peak after the first vaccination or after the second vaccination in that?
Yeah, it's a good question. Right. So the antibodies do come up really quickly in those folks. And that's sort of because we're now thinking about this as, effectively their second exposure to the antigens, to the spike protein. So the antibodies come up very quickly. You do get a little bit of a benefit of the second dose, but not much. So really what it looks like is in people that previously had COVID, one dose of vaccination really gives you almost your maximal immune response. The second dose doesn't seem to give you a whole lot of immunological benefit. I'm often cautious when I talk about this because we can measure the immune response and we can see these features of the immune response like antibodies, memory B cells, memory T cells, but we don't yet know which of those things correlate best with protection. We're assuming that it's neutralizing antibodies, but the data on that are still forthcoming. So we don't have an exact correlate of protection yet. We can make some assumptions based on other viruses and what we think is going to happen, but we get good boosting of the immune response after one dose in these individuals. We don't yet know whether there's a difference in protection, whether they get an increase in their protection from infection after getting the second dose as well.
And the other thing we perhaps don't know too is whether, I'm assuming that the interval between the first and second dose was something like, 2 to 4 weeks, but we don't know if there would be any benefit in extending that interval to like 12 or 16 weeks, for example.
That's right. The interval between vaccine doses is an area of a lot of attention right now. There's a little bit of data from the UK that suggests that a longer interval may have been beneficial to get stronger immunological memory. Canada also did the same thing, and they're studying those responses now. And there have been some studies in animal models suggesting that a longer interval might actually be useful. So some preclinical studies also support the idea that a longer interval is beneficial. Scientifically, this makes some sense. The immune system needs some time to mature and needs a little bit of rest. What happens when you extend the interval is that those memory B cells and memory T cells have time to mature and time to rest, rejuvenate, and get ready to actually have an even better boost response than if you shorten the window. Now, we made the decision, or the field made the decision to do this short interval between vaccine doses because we were in a pandemic. We needed to try to get people immune as quickly as possible. So I think as we move forward, we're going to see opportunities to play with the dosing and the timing of these vaccines and maybe even improve things.
Yeah, I was just thinking back to that terrible situation in Manaus in Brazil, where there was already a high sort of prevalence of exposure, and then another wave that caused another catastrophic epidemic. Do you think that if there had been a longer period between these two waves, maybe people would have been better protected?
Yeah, the Manaus experience is a very interesting one from a sort of epidemiological standpoint. There's a lot we don't know there, and we don't know really how good the reporting was, for one thing. But it is one of the places that people point to say that natural infection doesn't give you as strong immunity as vaccination. I think that's probably an overstatement of what happened in Manaus. And we do know from a lot of other studies that infection gives you good immunity. It can be protective, and in some cases, it's equivalent or close to equivalent to vaccination. Manaus, though, is a warning shot over the bow for us to remember that if the virus changes and you see evolution of the virus, or there's something else happening, a short interval, or some other reason why people are more susceptible, that we still need vaccines even in those settings, very likely. So we need to keep that in mind, and we also need to understand it a little bit better. And I think we'll have a number of other real-world examples of places that have a high infection rate, and then another wave of virus, perhaps Delta variant, comes back, and we can understand this immunity following infection a little bit better.
What does the research that you've done that sort of points to the maturation of memory B and T cells and how that is provides a level of cross protection. What does that say about how we're going to respond to future variants? And does this actually suggest that our future with COVID isn't quite so drastic? Once we get the whole world adequately immunized, is that going to have a significant impact on our relationship with COVID?
I'm optimistic, actually. We know that T cells are sort of less susceptible to the mutations that we're seeing in the spike protein in the receptor binding domain of spike. So they bind to other parts of the spike protein, and so that gives us some resilience there. The memory B cells are also really encouraging here. We're seeing specificity for variants that will perhaps mean we can cover variants we haven't seen yet. Part of that may be that these really mature memory B cells have perhaps a higher affinity, or they have a higher mutation rate, meaning that if there are mutations in the spike protein, those higher quality antibodies may be less affected by a mutation here or there. So I'm actually quite optimistic. I think what we've also seen from our studies and others is that those memory B cells, as they mutate their antibodies to get better, that's how the memory B cells get better, we're seeing a gradual improvement from starting with antibodies that bind to the wild type virus, the original virus, that can then move to bind better to these variants. So I think that means that we have a substrate there to work with. And if the virus changes, we could perhaps push that initial memory B cell response to get better and better against the variants. So, I think time will tell. The more the virus replicates around the world, the more variants we're going to have and the more concerning that could be. But right now, it looks like our immune responses are doing the right things and will be a useful substrate to make new responses in the future if we need to.
Right. So by and large, it feels like your paper doesn't make a strong case for a need for third doses, at least in immunologically sort of healthy people. Is that a fair statement?
Yeah, I think when we talk about boosters, we have to remember there are two goals. There's the public health goal. How do we actually end the pandemic? And then there's the individual goal. What do we need to do for individuals? And I like to take these apart in two different things. So the way we're going to end the pandemic is when people who are unvaccinated get vaccinated. That's what's going to end the pandemic. Vaccinated people are not spreading the virus very much, although they can spread. The R naught, that number of new people you infect for each individual who gets infected, is pretty low for vaccinated people. So boosting vaccinated people is not going to end the pandemic. Vaccinating the unvaccinated is. However, vaccinated people also should want to be healthy. We don't want to miss work. We don't want to have to stay home because our kids are out of school because they have COVID. We don't want to run the risk of something going wrong and being that odd chance. So I do think that there's a benefit of boosting people, even young, healthy people who've had 2 doses. We want to keep our workforce working. We want people to feel confident to get back to their normal lives. That's what's going to get our economies back on track. So I think as we move forward and we understand the value of boosting in healthy young adults a little bit better, I think we're going to see boosters become available. Now, that said, I think it should be individual choice. I think that people should have the option to get a booster if they want. As we understand the evolution of the pandemic and as things get a little bit better, the need for that booster may change and the importance may change over time. Yeah,
and how do you think about older people who are immunocompromised, who may not have mounted a strong immune response to a second dose? Is that a bit of a no-brainer that a third dose is going to be important for that cohort?
Yeah, I think so, but they're not all, there's not all one type of person there. So we have people who have gotten vaccinated and have made weak immune responses. And there's some good evidence now in transplant patients, cancer patients, and some autoimmune patients that a third dose will actually boost those weak immune responses up. But it doesn't happen in everybody. The transplant study from Johns Hopkins said in about a third of the transplant patients, a third dose gives you an increase in antibodies. Now, that still leaves 2/3 who don't benefit from that third dose. So I think what we're going to need going forward is an ability to measure the immune response after the first 2 doses and understand who's going to benefit from a boost, and then who may benefit from other sort of prophylactic protection. We have now monoclonal antibodies that can be used post-exposure. We may need to think about using them pre-exposure in high-risk individuals. And we have at least a few new antiviral drugs that will be available hopefully soon that could also be used in pre-exposure or certainly post-exposure in high-risk individuals.
Yeah, that makes sense. I was curious to know more about the germinal center response. Where are these germinal centers and what is the response?
Yeah, so there's wonderful data from Ali Ebbed, who has shown with lymph node aspirates after vaccination that germinal centers in your lymph nodes can last for 15 weeks after vaccination. Now, this is a really good thing. This is actually exactly what your immune system is supposed to do. So just for a little bit of background, these germinal centers are where the B cells and the T cells meet and have a little dance. And what happens in that dance is that the T cells help the B cells make their antibodies get better. And they do that by kind of testing. They go through a bunch of rounds of adapting those antibodies, making them get better and stronger over time. And then the best of the best make it out of the germinal center. They either go as cells to the bone marrow where they become plasma cells. And these are little antibody factories. They make an enormous amount of antibody and they can do that for a very long period of time. Or they form these memory B cells. And these are these memory B cells that we talked about that are then beneficial. And so these germinal centers are really this exciting place where all of the action happens. It takes some time. So the antibodies that you have in the first couple of weeks after being vaccinated haven't come out of the germinal center. So they haven't gone through this nice maturation process. And I think this is why we're seeing the memory B cell populations get better late, because it takes some time for these germinal centers to form, for them to do their job. So your immune system kind of divides and conquers. It makes a sort of emergency response, get some antibodies out there as quickly as possible, even if they're not optimal quality yet. Then set up germinal centers, let the immune system evolve, get better, and improve over time. And then as those first antibodies, the emergency response starts to come down, you get these better quality antibodies and memory B cells coming out that are available for future responses.
You mentioned that these germinal centers are in our lymph nodes. Are we talking in our neck, under our armpits, in our groin? Are they the sort of main places?
Yeah, that's right. So you get your vaccine in your arm, and it's going to be the lymph nodes under your armpit. And in fact, one of the side effects that we see following vaccination is people, a subset of people note that they have swollen lymph nodes. And this is not something to worry about. In fact, it's actually probably a good sign in this case that that's your immune system working. It can be a little uncomfortable for a couple of days, but basically that's what's happening. Your immune system is your lymph nodes are swelling up with germinal centers being activated. And so that's what people are talking about when they have lymphadenopathy or swollen lymph nodes after vaccination.
I just want to quickly ask about the functional difference between natural infection versus vaccine-induced immunity. In my mind, one of the issues, one of the differences is that the infection-induced immunity may be more sort of heterologous or maybe broader, and it's not as specific as you get from a vaccine. Is that correct?
Yeah, that is correct. And so what happens when you get infected is you make immune responses not just to the spike protein, but to many other proteins in the virus. And so that can be beneficial in some ways. The only immune response that's really going to prevent the virus from getting in, block all infection, is going to be an antibody response to spike. So infection-induced immunity is not necessarily going to give you better immunity from that initial infection, because really the vaccines are inducing the same kind of immunity to the spike protein. And in fact, what we've seen for infection-induced immunity is that there's a much broader range of antibodies. So especially in people that got mild infection, they tend to have a little bit lower level of antibody. Can be pretty durable, but it can be lower level. And so the vaccines give you a much more consistent immune response across the population. Now, infection-induced immunity, you also have T cells and very likely memory B cells to other proteins of the virus. And so that might give you more breadth, but those are only going to be relevant after you've been infected. And so perhaps you'll see a little bit stronger, maybe more broad response to limit severe infection, hospitalization. But that initial response to infection maybe equivalent to vaccination, maybe a little bit worse in some cases, could be a little bit better depending on the level of antibody. So there are a couple of studies that suggest infection-induced immunity might be on par or better than vaccination. Most of the data says that it's maybe a little bit worse, not a lot worse, 80% vaccine efficacy versus 90, still quite good. The concern that many folks have is that the breadth of coverage of infection-induced immunity might not be as strong. So if you got infected with the original strain, a year and a half ago, your antibody levels have probably come down, and you don't have as good a coverage for the Delta variant as if you had gotten vaccinated. So there's still some debate about this in the literature, still some science in progress to understand infection-induced immunity versus vaccination-induced immunity. But to be clear, infection does generate a good immune response. There's some protection from that. You can increase that level of protection by getting at least one dose of vaccine on top of that.
What do we know about the levels and durability of neutralizing antibodies post third dose of vaccine or third exposure if you had already been vaccinated after a COVID case?
Yeah, your neutralizing antibody levels go up quite substantially. So we don't yet know a whole lot about the quality of those antibodies with the third dose of vaccine. Most of that data is coming from either Pfizer or Moderna or Johnson & Johnson in their 2-dose schedule for boosting. But definitely you see an increase in neutralizing antibodies. They may go up 5-fold to 30-fold. They can go up quite a lot. What we're not sure of yet is how long they last, whether we've changed the kinetics of decline. And our studies suggest that infection followed by vaccination, the rate of decline of antibodies is about the same as it was just following 2 doses of vaccination. There is some evidence that infection followed by vaccination, the quality of the antibodies may be better. And Shane Crotty and others are calling this hybrid immunity now, which is the best of the combinations of things we've seen so far. So it does look like getting vaccinated after you've been infected can actually give you an even better immune response than just vaccine alone. Whether that means you have a substantially higher level of protection or that protection is more durable, we don't yet know.
What about the heterologous prime boost approach where you change platforms? I got 2 AstraZenecas, got a sneaky third dose of Pfizer because my GP friend was going to throw it out, so she put it in my arm. I'm just wondering what we know about the mix and match approach to immune responses.
Yeah, there have been a couple of studies, and mixing and matching is something that vaccinologists really like. This is what the HIV field and other fields have been doing for a couple of decades now, and there's good reason for that. And so we know from a study in the UK that AstraZeneca followed by Pfizer actually looked really good. There was good immune responses, maybe a little bit better than just AstraZeneca alone. We've now seen there was a study last week that came out that mixed and matched Pfizer, Moderna, and Johnson & Johnson in every combination. So Moderna followed by Pfizer, Johnson & Johnson followed by Moderna, and so on. And there, it does look like the mixing and matching has some benefit. And it was especially beneficial for Johnson & Johnson followed by either of the mRNA vaccines. There's a much higher boostability of those responses. So this may have to do with just different ways of presenting the bits of the virus to your immune system. You can think about this like, doing a workout. If all you do is the same exercise over and over again, you reach some plateau. Whereas if you mix up the exercises and you have this sort of, variety of ways of stimulating your system, you do a little bit better. And I think that's a simple analogy for what's probably happening here with mixing and matching. Question is whether, at least in the US, the FDA is going to approve that. We'll probably see some activity on that in the next few weeks here in the US to see what might be possible. But as you point out, there's a lot of real world mixing and matching going on. So the sooner we can understand this, not just immunologically, but in terms of how protection is affected by mixing and matching, I think the better we'll be.
Yeah, it sounds like the UK will be perhaps our best source for that data. I
think so. They've the longest experience with this so far. And so watching that AstraZeneca followed by Pfizer will be very important. I think there may be some data out there on that already.
It sounds like there's not really good evidence that, for example, Moderna followed by Johnson & Johnson is going to be all that beneficial.
It still boosts antibody. I mean, I think that, we look at this and this is, maybe the grass is always greener kind of thing, where just because the one next to you was really phenomenal, 30-fold or maybe even more increase in neutralizing antibody, the 5-fold increase that you get with that combination seems, well, not so great. Still, a 5-fold increase is pretty good. We have to remember also that Moderna probably has a higher baseline level of antibody than the others for a bunch of reasons. And so you're starting already at a higher bar. And so boosting that may just not be as easy.
Gotcha. Cool. Is there anything we haven't talked about that you wanted to mention?
No, I think we covered just about everything here.
Yeah. And sounds like correlates of protection are still being worked on. Do you get any sense of when we may have some guidance on that?
Yeah, there have been a couple reports on this already. I think one of the challenges is having a unified platform for measuring antibody. There are different tests being used in different places. So there have been 1 or 2 studies. I think we just need to get to a universal metric for measuring these spike receptor binding domain antibodies. I suspect we'll see activity on this over the next few months now that people have gotten a little bit of bandwidth back, because we've started to see some progress in controlling infection spread.
And do you think that the humoral response will be sort of fairly key in providing that protection?
I think it will. Certainly neutralizing antibodies are going to be a key mechanism here. Whether they're the only mechanism, whether they're the best correlate, we don't know. Certainly other parts of the immune system can contribute and are contributing. One of the challenges is that measuring anything besides antibody is really labor intensive and very difficult to do in a clinical scenario and very difficult to do on large scale trials. So we want something that's really easy to measure. And this is why we talk about correlates of protection, not mechanisms of protection, because we just want something that we can measure quickly and easily. And it may not always be the mechanism, but at least correlates. I think here, very likely the neutralizing antibody are going to play a major role in the actual mechanism of protection as well. But they certainly will correlate with other parts of the immune system.
And when we talk about protection, are we talking about protection from infection or protection from disease or severe disease, hospitalization?
That's exactly one of the other things we have to sort out is what is the metric that we're looking at here? And typically correlates of protection look at protection from clinical disease. And most vaccines haven't really been addressed, haven't been looked at all that carefully to know whether they prevent any infection at all. One of our best vaccines, measles vaccine, protects all of us for our entire life from measles. But if you put someone who's measles vaccinated in a room full of people with measles, they won't get sick, but they'll end up with a virus in their nose replicating. So this issue of whether we are placing too high a bar on what we're asking the vaccine is really important when you get to this issue of correlates of protection. Is the goal to prevent any virus from getting in anywhere that we can detect by these sensitive PCR assays, or is the goal to keep people from getting sick or to keep them out of the hospital? So I think defining that is going to be really important for correlates of protection, and different countries may do that differently, at least initially.
Yeah. Do you think also we need to be asking the question, is it protecting against long COVID? Like, is that something that is sufficiently of sufficient concern to look at what these vaccines are doing for that risk?
I think it's a huge concern. The initial data does look like vaccination does prevent long COVID or reduce your risk of long COVID if you get infected. So that's really promising news. I think long COVID is something we have to keep in mind. It's going to be, if nothing else, it's going to be a healthcare cost burden going forward. And so we need to keep an eye on that. We need to figure out how we're going to address that. Using that as a readout for correlates of protection will be very difficult just because of the time lag in defining it. But we're starting to get better clinical definitions of what long COVID really is. So at least now we can define it. We now have a clinical code in the US for long COVID. That was just last week. So that's a big deal. We can actually now start to extract from medical records the number of people with long COVID, track them over time. So I think we need to keep an eye on long COVID for sure. It's something that we're going to be dealing with for a while, and will be a real burden just in terms of health and productivity, but also healthcare costs.